right, it's a little after 2 o'clock. We appreciate everyone joining us for the, what are we, February Valentine's Day edition, if you will, CED Ability Grand Rounds. And just as a reminder, before I get a chance to introduce our presenter for today, which I'm very excited about, just remind everyone as you enter the room, remember to mute your background. With that being said, we do encourage questions, discussions, and we'll set a little bit of time toward the end of the presentation if no other time comes up before then for questions for our speaker. But until then, just to kind of keep the noise level down, we know telephones and work continues as we do this. Just mute your background as we go. If you're not familiar, we do have closed captioning available. You can request that in the menu buttons at the bottom of Zoom. If you need assistance with that, feel free to put that in the chat and we will send you the particular instructions. This is recorded, and that's just for people who expressed an interest in the topic but were not able to join us. We'll be able to get these. These are on our website after the fact. So with that being said, let me go ahead and quickly go through and introduce our speaker for today. You can see the title, Towards Disability Equity Using National Data. So today we're going to be talking about data, but also implications of that data. And many times it's pertinent in many areas of disability. Dr. Varshini Varadaraj is from Johns Hopkins Disability Health Research Center. And is particularly a research associate at the Johns Hopkins Disability Health Center. She completed her medical and ophthalmology residency training at Sri Ramachandra University in India and received her Master's of Public Health from Johns Hopkins Bloomberg School of Public Health, with particular concentrations in epidemiology and biostatistics. She completed her postdoctoral research training at the Wilmer Eye Institute at the Johns Hopkins School of Medicine, where her research goals are particularly to improve the health of older adults with disabilities with a focus on vision loss using a data-driven approach, which we should all have a goal of doing. And her research focuses on examining disparities in health and healthcare access for people with disabilities. Her work has broadly concentrated on two interrelated areas, which are aging with vision loss and access to care. So these are all topics of near and dear to our heart. And so we look forward to hearing more from your experience and your work. Hand it over to you. Thank you so much for your time.
Thank you, Dr. Cottrell, for that introduction, and good afternoon, everyone. I'm very grateful for this opportunity to talk to you about some of my work in the area. And I will begin with a visual description. I'm an Indian woman in my 30s with long black hair, wearing a green top with a black blazer. And there's a picture of a cow in the background. So the objectives today will be to learn about the Johns Hopkins Disability Health Research Center, where I work, discuss disability prevalence using national data, understand inequities in the spheres of healthcare access, community participation for people with disabilities, and particularly with a focus on vision disability. Dr. Bonnie Sweenor is the director of the Disability Health Research Center, Johns Hopkins. She's a fantastic mentor and leader in this field of work. At the center, our motto is to use a data-driven approach for shifting the paradigm from living with a disability to thriving with a disability in order to reduce disparities and maximize health, equity, and participation for people with disabilities. To achieve this, we have 4 strategic goals. One is to fill disability data gaps. In order to drive change, we need data. We need data to identify the disparities that people with disabilities face in the realms of health, healthcare, employment, education, and to track change and to advocate for better policies. 2, our goal is to address barriers to health equity. And even with disability data gaps, there are known inequities for the disability community, not just in healthcare outcomes, but also in food access, transportation, education, employment, etc. And we're focused on creating strategies to decreasing these barriers. 3, in training the next generation of disability researchers. We recognize that disability is a critical dimension of diversity, and the center is working to increase the inclusion of people with disabilities in research, higher education, and across STEM and healthcare. And lastly, it is our goal to partner with the disability community. Just as we have learned from other groups, disability research must actually include the disability community through true partnerships, including people with disabilities as collaborators, researchers, and leaders, and also giving back the research results and to inform the community. So for this talk, I will highlight some work that we're doing at the intersection of disability and vision loss within the spheres of healthcare, community living, and participation in STEM, or science, technology, engineering, and mathematics. And I'll do this using various data sources. 1, nationally representative data sets, 2, electronic health records, 3, qualitative data from focus groups and interviews, and finally, what we call disability dashboards at the center. We recognize that data is a powerful tool for change, and our dashboards provide access to a range of disability information in an accessible and publicly available format. And by prioritizing accessibility, we aim to create resources that everybody can use. So what is disability? Disability is defined in many ways. Estimating the number of people with disabilities in the US is difficult because individuals face a broad range of impairments, and the definition of disability depends on the context for which it is defined. Starting broadly, the WHO, the World Health Organization, states that people with disabilities are diverse, while stereotypical views of disability emphasize wheelchair users or blind and deaf people. Disability encompasses the child born with cerebral palsy, the middle-aged woman with arthritis, or an older person with dementia, among many, many others. And finally, disability is part of being human. Almost everybody will temporarily or permanently experience disability at some point in their life. But in terms of filling data gaps on disability numbers, we have to start somewhere. In accordance with the 2010 Affordable Care Act, the US Department of Health and Human Services, the HHS, established data collection standards for disability in national surveys. So according to this guidance, the 6-item set of questions that the American Community Survey, or the ACS, which is a commonly used national survey in the United States, that is the minimum data standard for survey questions on disability. So while not perfect and not the broadest, they capture a broad range of difficulties with hearing, vision, cognition, mobility, self-care, and independent living disability. Since the establishment of these data collection standards, the 6-item set of disability questions has been included in several population surveys to assess the health status of people with disabilities. One such national study is the Behavioral Risk Factor Surveillance System, or the BRFSS. The BRFSS is a state-based cross-sectional telephone survey of non-institutionalized US adults aged 18 and older. And in a recent paper using data from the year 2019, we calculated the national prevalence of disability. And we found that in the US, 67 million American adults have a disability. That is 27% of the adult population, making disability extremely common. That translates to 1 in 4 of us, making it the largest minority group and the only minority group that one can join at any time. Of note, this 27% in 2019 is a 2% increase from the last update in 2016. So we expect the percentage of the US population with disability to continue to increase as the population ages and lives longer, making disability and disability data that much more pertinent as time goes on. So looking at the 6 disability categories I mentioned, we found that mobility disability was the most common at 13%, defined by the question, do you have serious difficulty walking or climbing stairs? Followed by cognition. Because of a physical, mental, or emotional condition, do you have serious difficulty concentrating, remembering, or making decisions? 7% with an independent living disability, defined by because of a physical, mental, or emotional condition, do you have difficulty doing errands such as visiting a doctor's office or shopping? Hearing disability, defined by are you deaf or do you have serious difficulty hearing? Vision, are you blind or do you have serious difficulty seeing even when wearing glasses? And lastly, self-care disability, defined by response to the question, do you have difficulty dressing or bathing? Looking at the 6 disability categories I just mentioned, we see that, again, this definition is not perfect, right? It doesn't capture mild impairment, and mental health is not well captured. On this slide are bar graphs from the same paper indicating that as compared to people without disabilities, a higher percentage of adults with disabilities have less than a high school education, have a household income of less than $25,000 per year, and a higher percentage are unemployed. And these results highlight that inequities exist for people with disabilities. But the experience of disability is not the same for everyone. We need to also recognize that people with disabilities from other intersecting minority groups, such as from the Black or Hispanic communities, face compounding or magnifying inequities. On this slide, I'm showing additional data from the same paper indicating that disparities in education, income, and employment are greater for people with disabilities who are also Hispanic, Black, or from other minority, racial, and ethnic groups. So we've seen disability defined as collected by a national survey, but the shift in where we collect disability data also needs to occur outside of national surveys to electronic health records in our hospitals and clinics. But unlike race, ethnicity, gender, and age, disability data is not routinely collected in electronic health records. And while there's a move to do that, it is still largely missing. And without that information, we cannot track inequities in healthcare, food security, education, etc., for people with disabilities. So in this study, it was a cross-sectional pilot conducted at the Wilmer Eye Institute at Johns Hopkins. We implemented an electronic health record questionnaire and prospectively collected data on accessibility requests for patients making an appointment at the eye clinic. It included about 55,000 patients making appointments between April 1st, 2019 and the end of March 2020, so a 1-year period. And so over this 1-year period, we found that almost 10% of patients making an eye appointment had an accessibility need. The most commonly reported was a mobility limitation, needing a crane, crutches, a motorized scooter, walker, wheelchair, etc., followed by sensory impairment, which included vision, hearing, or speech impairment, and other included requiring assistance with filling forms and a service animal. It's important to note, though, that we collected data on the percentage of patients with accessibility needs, and that does not equal the total percent of patients with disabilities, as not all patients with disabilities have accessibility needs. So moving forward, what we need to do is standardize data collection for disability and disability-related accessibility need requests in electronic health records. What percent of patients have a disability? Are there inequities in healthcare outcomes? Can we streamline healthcare accessibility requests for these patients? And are accessibility requests actually being met? These are all research questions that still need answering. As recommended by Drs. Bonnie Sweenor and Megan Morris in this health affairs piece, disability status should be collected as a core demographic included with other demographics such as age, race, ethnicity, etc. It needs to be completed by the patient, separate from clinical and benefit program data elements. And lastly, these disability questions need to be standardized across platforms to support interoperability. So to sum the first section, we see that disability is very common and still data gaps exist, and we need to move towards wide and standardized disability data collection. Next, we will look at some studies examining how disability may affect access to healthcare, with a focus on vision loss. Understanding healthcare usage over time is essential to estimate continued unmet healthcare needs for people with disabilities. In this paper, we use data from the National Health Interview Study, another national survey of US adults over a 9-year period. We combined data from 2008 to 2016 to examine trends over time. And we found that people with vision difficulty, shown here in blue, were more likely to use eye care than people with vision difficulty, shown here in orange. But they were also more likely to have difficulty affording eyeglasses. So what does this indicate? That while eye care utilization is pretty equal, there are still healthcare access gaps to fill for the people that need it the most. In another paper led by Dr. Lama Asi, who was a postdoc with us, also using data from the National Health Interview Survey, we examined if people with vision loss had equal access to breast and colon cancer screening. And we found that individuals with vision loss were less likely than those without to report having received breast and colon cancer screening across age groups, as depicted in this bar graph. And when adjusting for a range of confounding variables and regression analyses, we found that women with vision impairment had an 18% lower odds of a mammogram, and men and women with vision impairment had 11% lower odds of receiving a colonoscopy as recommended. And these data show just a snapshot of the picture on health inequities that people with disabilities face. So now that we've looked at some national surveys, I want to introduce you to our center's disability dashboard approach. When we started this project, the disability community was experiencing clear inequities in the early stages of the vaccine rollout. And we came up with the COVID vaccine disability dashboard. We launched this in early 2021. And so the COVID-19 pandemic clearly exacerbated existing inequities for people with disabilities, including barriers in accessing online information and healthcare appointment websites. And these barriers were brought to the foreground during the vaccine rollout and registration process. And to help elevate this issue and put some quantitative data around this inaccessibility, we launched this public-facing dashboard to assemble the data that was available to us in an effort to highlight disability inequities across states in the US during the vaccine rollout. This work was conducted with a group of highly motivated undergraduate students at Johns Hopkins, and Grace Zhou led the paper published on this work. And you can find information on this dashboard and the others that I will discuss on our website at disabilityhealth.ghu.edu/dashboard. So this COVID-19 vaccine dashboard collected data from health departments of all 50 states, the District of Columbia, and 5 US territories. And we looked at both the main COVID vaccine information page, where someone would go to look for information on the vaccine, as well as the COVID vaccine registration pages, where you would go to actually sign up to get the vaccine. And we updated this information weekly between March 30th through April 5th in 2021. And we prioritized the accessibility of the information we collected on our dashboard so that people with disabilities could access this information, since they're the population that we serve. So to create this, we worked with WebAIM out of the University of Utah. They are experts in assessing the accessibility of websites using a tool that they developed that's called WAVE. WAVE is used to score the accessibility of website content. So working with WebAIM, we assess the number and types of accessibility errors on these web pages. Error types included insufficient contrast, alternate text, unlabeled buttons, error density, and so on. We also used an additional algorithm to account for differences across websites, such as the length and density of language on the web page, so that we could compare across websites. We then used those scores to rank websites by US states. And our dashboard also compiled this data, including the URLs, the specific URLs of the websites that we graded, so that the process was transparent. So to improve accessibility, we also included these data visualizations of the US map by states. The accessibility scores that we collected in partnership with WebAIM, we categorized them into tertiles or 3 groups, denoting the top, middle, and bottom 1/3, or the fewest to the most accessibility errors. And I show here the map for the information pages. And overall, we see that there was wide variation. Where you lived could factor into how easily or how difficult it may be to access the vaccine if you were blind or had low vision. But this is not just for vision impairment. There are a lot of people who use screen readers or need accessibility features on websites, people with ADHD, mobility disability, and so on. And these results highlight barriers that people with disabilities may encounter when accessing information and registering for COVID-19 vaccines, which could create delays in or prevent vaccine registration for people with disabilities. And again, these data underscore inequities in the pandemic response for the disability community. So we see that although disability is so common, health inequities remain unaddressed for the population. For very long, pursuits of health equity for disabled people have not been prioritized, and that could be why we see these health inequities. Moving on to the next 2 spheres, disability and community living. I'm going to highlight some other studies. So here in this study, we use data from the National Health and Aging Trend Study, which is a nationally representative study of Medicare beneficiaries 65 years and older. And since financial capacity is central to independence and well-being, we were interested in understanding the interplay between vision loss and dementia and its impact on financial well-being of older adults and their caregivers. So starting with the bar graph, I'll quickly go over the distribution of the unadjusted outcomes. We see here that there's almost dose response increase in debt as we go from having no impairment to vision to dementia to having co-occurring vision and dementia. And this was a very similar story for having received financial help from relatives and receiving assistance with utilities, as well as receiving government assistance via SNAP or the Supplemental Nutrition Assistance Program. And sorry, for some reason, my slides are moving by themselves, and as well as receiving other food assistance such as Meals on Wheels. In regression analyses, adjusting for a range of confounders, having vision impairment, dementia, and both conditions were associated with worse economic outcomes, including debt and food assistance. For example, focusing on the outcome of debt specifically, having either vision impairment or dementia was associated with similar odds of only paying the minimum on credit card bills each month, about 60 to 90% greater odds, as compared to those without either impairment. While older adults with co-occurring vision impairment and dementia had considerably greater odds, about 400% greater odds of only paying the minimum each month. Since we also saw that the association of vision difficulty with needing food assistance in the previous study, we examined this association further in another data set. Well, food security is central to health and well-being. It's defined as the limited or uncertain availability of nutritionally adequate or safe foods. and has been linked to poor mental and physical health, including limitations in activities of daily living and greater prevalence of chronic conditions. Adults with disabilities are more likely to live in food insecure households than those without. 33% of households that include an adult with a disability are food insecure, as compared with only 8% of households including adults with disabilities, without disabilities. Now, various disabilities have been found to increase the likelihood of food insecurity, including physical, cognitive, and hearing limitations. However, the association between vision loss and food insecurity remains poorly understood. And that's what we sought to do. So we use data from the National Health Interview Survey, which we've seen before, and this work was led by a medical student who worked with us, Priyanka Kumar. In unadjusted analyses, low-income adults with vision impairment were more likely to be food insecure at 43%, as compared to adults without vision impairment at 26%. And examining the food insecurity using ordinal categories, we found that low-income adults with vision impairment had higher levels of food insecurity than low-income adults without vision impairment. In regression analyses adjusting for a range of confounding variables, we found that adults with vision impairment experience more than double the odds of being food insecure than their peers without vision impairment. And in a multinomial regression model, there was this dose-dependent relationship that we saw, where vision impairment is associated with increasing odds of food security, a degree of food security. Moving from an odds of 1.6 to 2 to 3 for very low food security. So in summary, we found that vision impairment was associated with food insecurity, but also operates in a dose-response manner with greater levels of food insecurity. And vision loss, vision disability may be driving food insecurity due to challenges with not only acquiring and preparing food, but also the accessibility and affordability of social services, such as transportation and navigating online platforms for food programs. That brings us to the next disability dashboard, the SNAP disability dashboard. We developed this to assess the accessibility and transparency of information about the disability inclusive process and practices of SNAP enrollment. The Supplemental Nutrition Assistance Program, or SNAP, just to give you some background, is a federal public benefit providing assistance to millions of Americans. This work was led by Dr. Laura Samuel, an expert on food security and food assistance programs in the US who's faculty at the Disability Health Research Center. We collected cross-sectional data from SNAP landing pages and enrollment web pages from all 50 US states, the District of Columbia and New York City, in June to August 2021. And based on the principles of universal design and accessibility, scores were determined for each SNAP program across 3 areas: flexibility, efficiency, and accessibility. And they each received 6 points each for a total score that could sum to an 18 points. And we found, from this map, we found state-based differences in the accessibility, flexibility, and efficiency of SNAP enrollment information available on these websites. And these results are important to note because all income eligible households are legally entitled to receive SNAP benefits, which can reduce food insecurity. And together with evidence showing disproportionate food insecurity burden among people with disabilities, these results suggest that people with disabilities are doubly disadvantaged with regard to food access. And improving the accessibility of SNAP and other food programs may help boost enrollment and lower food insecurity for people with disabilities. Moving on to some qualitative work, this project was led by Sabrina Epstein, an excellent student and disability advocate who worked with us at the center to identify how COVID-19 uniquely impacted the disability community. We recruited through disability advocacy groups and social media, a group of about 40 adults who self-identified as having a disability, and conducted virtual focus groups via Zoom. It was during the pandemic for each of 6 disability subgroups: vision, hearing, mobility, mental health, cognitive, and chronic illness. And from thematic analysis of the qualitative data, 3 major themes were identified: new problems created by the pandemic, obstacles in daily life that were exacerbated by the pandemic, and broader changes to accessibility and disability identity. And sub-themes such as difficulty with COVID-19 testing and regular medical care were reported by participants of all disability subgroups. And we see here in this bar graph that all disability subgroups were identified with multiple difficulties, as shown here. In reflecting on how COVID-19 has disrupted daily life, one participant captured this major theme with this succinct statement: if the gap exists before a major health crisis, you better believe that that's going to become the Grand Canyon when something like this happens to us. So the historical inequities that impact the disability community are only likely to widen, and we've seen them widen after the pandemic and during it. Another participant said, food access was scary to me, if not scarier than COVID. And another participant said, the paratransit system in my area will not only deliver you or pick you up from will not deliver you or pick you up from a testing site if you can't get there on the bus or on your own. And again, taken together, these results highlight that from grocery shopping to taking public transit, that these common barriers facing people with disabilities have been exacerbated by the pandemic. In another qualitative study, also conducted during the pandemic via Zoom interviews, led by a medical student, we recruited adults with glaucoma and macular degeneration, age-related eye conditions from the eye clinic. And several themes of internalized and externalized stigma emerged. One participant said, when talking about people with severe vision disability, I think it hurts them because they are targeted as different. They are targeted as not a whole person, as being a lesser person. I do feel that people feel rejected in general. I show this to highlight that there's a lot of work to be done in addressing and alleviating the stigma, discrimination, and ableism that very much exists for people with disabilities. So in total, we have seen that community living disparities exist for people with disabilities in the realms of food insecurity, participation in food assistance programs, and economic outcomes like having debt that have been further magnified by the pandemic. Next, we're moving on to examining some of our work at the intersection of disability and STEM and higher education participation. In this work, led by Dr. Franz Castro, a postdoctoral fellow at the Disability Center, we leveraged cross-sectional data from the 2019 survey of doctorate recipients. It is a biennial survey conducted by the National Science Foundation. And this survey collects information from individuals that obtained a US research doctorate degree in a science, engineering, or health field. Before I get into the results, to better characterize the impact of age of disability onset on career outcomes, we group disability into disability that was first identified at 25 years of age or later, and disability first identified before 25 years of age, so early onset disability. This is a bar graph from that work comparing prevalence of leadership roles for those 3 groups. We found that doctorate recipients with disabilities are underrepresented in academic leadership roles, including in faculty rank, tenure status positions, academic administrative positions, and for receiving federal funding. The tallest pink bars represent people with no disability. The purple bars represent people with disability that was identified at 25 years or later, so late onset. And the orange bars identify early onset disability. And they had the worst outcomes. We also, in the same work, we also compared salaries between doctorate recipients with and without disabilities who were currently employed in STEM occupations, adjusting, excuse me, for a range of confounders to find that in STEM, people with early onset disabilities made almost $11,000 less than people without disabilities. Further, focusing on STEM and academia specifically, this was further magnified. People with early onset disabilities made $14,000 less than people without disabilities. So these data highlight jarring STEM workforce disparities for people with disabilities and potential reasons for lower salaries among workers with early onset disabilities could be differential access to career advancement opportunities, lower access to research grants, specifically in academia, and systemic obstacles likely compound over time. So think about inaccessible 12K preparation, and then lower expectations from teachers and faculty, this idea of ableism, and therefore insufficient mentoring, and inaccessible institutions, all causing these disparities in STEM that we see. Now, focusing on inaccessible institutions, we move on to our last and the final dashboard that I'll discuss here today, the University Accessibility Dashboard. The data collected for this work was led by a great team of undergraduate students, a lot of them students with disabilities in STEM, including Jessica Campanelli, who led this work. She's currently a medical student. And this cross-sectional study assessed disability inclusion and accessibility at the top 50 NIH, National Institute of Health funded undergraduate programs in the US. We assessed disability inclusion and accessibility using 10 indicators spanning 4 categories. 1, accessibility of the built and virtual environment. 2, the public image of disability inclusion. 3, grievance policy and processes. And 4, accommodations, processes, and procedures. And based upon the total points, each of these schools that received NIH funding was scored out of a total score of 100. And based on that, they were divvied up to get a letter grade ranging from A to F. We found that of the top 50 NIH-funded institutions, 6% received an A grade on the score, while 60% received a D or an F. And these results show much room for improvement for many schools and the need to follow ADA recommendations and to take actions to be more inclusive. So taken together, these data highlight that people with disability are underrepresented and face inequities in STEM participation, both at the educational and professional levels. And the inclusion of researchers with disabilities must be a priority. Including researchers from diverse backgrounds enriches our public health efforts and expands our research focus. And to increase representation of people with disabilities in STEM professions, it's vital to pinpoint the accessibility barriers that make higher education and academic institutions disproportionately difficult for disabled students and researchers. So, taking all of this together, we have looked at disability disparities across the realms of healthcare, community living, STEM education, and workforce participation using different data sources, quantitative data from national surveys and electronic health records, qualitative data from interviews and focus groups, and finally, the disability dashboard approach that I described. And despite the fact that 1 in 4 among us has a disability and that anyone can develop a disability at any time, these disparities across health, community living, and STEM participation continue. Accessibility is all of our responsibility. Inaccessibility includes barriers to information, such as what we saw with the COVID vaccine dashboard and the SNAP dashboard that can be exacerbated for people with disabilities, to services and programs and facilities that we saw for eye care affordability, for mammograms, colonoscopies, and environments for people with disability. Access must be equally effective and integrated and of equivalent ease of use as for people without disabilities. I'd like to end with a quote from the director of the Disability Center, Dr. Bonnie Sweenor. The future of health equity research and policy must be holistic and intersectional and must include disability. So continued research aimed at maximizing the health and inclusion of people with disabilities is crucial. We've seen that the COVID-19 pandemic has only magnified the urgent need for disability to be viewed through a lens of health equity. And without disability data, it is impossible to create inclusive evidence-based policies and strategies. And so now's the time to expand the scope of health equity to include everyone in our communities, including people with disabilities. Thank you all so much for listening. You can learn more about the Johns Hopkins Disability Health Research Center at our website. You can follow us on Twitter. And I would like to thank the entire DHRC team for all their contributions to this work. Thank you all very much.
So thank you for a great presentation. You covered a lot in this. I don't know where to start. Let's go ahead and open it up for questions. Please feel free to post it in the chat. You're getting a lot of thank yous and great presentations. I love all the data. I guess to get us started, while people think about their question, raise your hand too if you'd like to answer a question. We'll call on you. SNAP funding. You spoke about that and the access and use. We have a SNAP is managed through our extension office here at West Virginia University. We have reached out and talked a lot about collaborating. What would you think? What would you, based on your work in this area and the team's work in this area, what would be the first initiative that we really should try to work on in that growing collaboration?
Great question. So as we saw in the SNAP disability dashboard work, improving the accessibility of the information that's presented on a website is, to me, very low-hanging fruit. If we worked with website accessibility experts, you can work to decrease the density of the information, contrast errors, alerts on a web page that make it that much easier for someone with a vision disability, intellectual disability, anyone that uses a screen reader to access that information. But that's just the first step. It's the very first step. And this is just for someone who to check if they were eligible, and if they were eligible, to begin to sign up for the SNAP program. So following this, there are all the other steps of completing the questionnaires, actually getting the benefits and continuing to get those benefits, including the idea of stigma that exists around receiving the SNAP benefits. So to answer your question, I think there's work to be done in all of these areas, but the very first step would be to look at the websites, work with somebody to see how accessible that information is. because we've seen that people with disabilities are more likely to live in food insecure households. And so if they're more likely to need food assistance programs, but the programs are less accessible, it's like this compounding difficulty that sets in. So I would say first step, websites, and then moving on from there.
Wonderful. Thank you. Cortland, I'm going to turn it over to you. I see your hand raised.
Thank you. Thank you. Also, thank you for a really lovely presentation. Thank you for taking the time to speak with us here. I think a question I have, it's just been something I've been sort of wrestling with here. I feel like you've touched a little bit about how fluid a category disability is in so many ways, right? Sort of, what bodies and minds sort of are constituted as disabled, sort of, it's very, socially context dependent. It's very, again, it holds a lot of fluidity to it. How does one, I suppose, in your experience, sort of reconcile data collection, because data sort of by its very nature is a bit more static, it's a bit more reductive. We need to sort of create these categories and codify them. This body mind goes into this, designation, and so on and so forth, which is necessary to, create the data. But how do you sort of balance that with, this finding that, oh, these categories are really fluid, and what we codify right now might not capture the whole story about sort of what is disability, even as a sort of overarching concept?
Yeah, very important question, because it is at the crux of all the research data we collect and the questions we answer is how we define disability. And you're absolutely right. We sort of have to force feed categories and create these categories where we say people either have this disability or this disability, and that's not always the case. Disability may be temporary, it may be permanent, it's time dependent, it can vary in severity. Someone coming to vision loss, someone might just have difficulty seeing that can be corrected with glasses, and someone else might have a chronic eye condition. Someone else might just have difficulty functioning every day with their vision. So we definitely force feed some of these definitions. But like I was saying, and as you said too, to quantify disability and to get estimates at a national level from our electronic health record data, we kind of have to do this, standardize how it's collected so it can be compared across different settings. But you're right, and if you're thinking, and we're moving in the disability world from the medical model of disability, where it's defined by one health condition, that's to be fixed by a healthcare professional, to the social model, where disability is defined as a social construct like race, ethnicity, etc. And it's more so to do with how we create inclusive environments where everybody can thrive. So to answer your question, I think it is important to have a standardized set of questions, because data is power, and that's what drives policy. And we need to quantify those numbers to move policy. But which is why I think it's simultaneously important to do qualitative studies where we can use perhaps wider variations, wider definitions of disability, look at intersecting identities of disability to delve deeper into how it's defined. I agree with you. The definitions we use are not perfect, but I think it's a start.
Thank you very much. Appreciate it.
Thank you.
And then we have appreciate Al Shrubnik's comment. Thank you, represented from that comment. I don't know if you can see the chat. Disabled speech and low vision.
Oh, I'm going to stop sharing. I didn't realize I was still sharing my screen.
It's okay. It's pretty background. It's completely fine. Yeah, but describing that you represented their experience, that could be your poster child of what you studied and found to be true. So thank you for the supportive data.
Yeah, thank you. Thank you for your comment. I think that data are so important. And like I was saying, we collect other demographic information, right? We collect age, race, ethnicity in all research studies that we do, and we absolutely must include disability as a core demographic, because it is part of someone's identity, and it's a very important indicator of so many of these outcomes that we've seen. So thank you for your comment.
When and if we mentioned data, and then close on this point, I think the idea of your dashboards as well as your qualitative pieces, the different sources and the purpose and the importance of having that. Have you found the use of those 4 different sources of data to be true no matter what you're doing, whether it's a presentation for grand rounds or other audiences for other purposes, that having that people respond to the dashboard, they respond to these types of formats to move efforts forward?
I don't think I fully understand. Do you mean like from a community perspective or a policy perspective? And
really any audience, do you find that the dashboards and the qualitative pieces, the combination that you've presented to us for this purpose today, grand rounds, it seems so so powerful, and from different perspectives, with the data, that it's very useful tool.
Right. Yeah, no, absolutely. It's sort of I think they all kind of click together into a puzzle to give you the full picture. Quantitative data are great. So, for example, the BRFSS, or the National Health Interview Survey, there are tens of thousands of people surveyed each year. So we have these large estimates. We can quantify disability and look at these intersecting identities and a wide range of health outcomes that are available in these data sets. So so for like a wide breadth of information, national data sets are great. And then qualitative data helps us sort of really dig deeper and moving towards this idea that the identity of disability is complex. It's very complex, and the focus groups and the interviews allow people, given the chance, to get into that a little bit. So I think but the most important, I would say, so the dashboard approach really is geared towards giving back to the disability community, rather than conducting research on somebody with disability, but without really having the findings translate back to the community. That was the thinking behind it. So we've made all the data publicly available, very accessible. Anybody can go on the website, download it, look at scores, look at where their state scored with SNAP enrollment or the COVID vaccine rollout. So just to give the power back to the community in terms of data. So I think that is appreciated. And from a policy perspective, I think even more than the qualitative, the national quantitative data, because all of these data sets are paid for by federal dollars. They come out every year. So they are more incentivized, I feel, to respond to these gaps that are highlighted using their data.
Yeah, I think that's wonderful. And I think so on here, we have representation from several programs. And so to utilize that approach to take on that mission in what we're doing, to have involvement and to share information in that way, I think is a lesson in and of itself from today. So thank you very much.
Thank you.
Any other questions before we part today? All right. Well, thank you again for your time. There was a lot of great work. I'm going to follow up with you personally about a couple of things that seem to really suit us here in West Virginia. But thank you very much.
Thank you so much. That sounds wonderful. I look forward to hearing from you. And thanks again for this opportunity to talk to all of you.
Absolutely. Everyone have a nice afternoon. And thank you for sharing your time.
Bye.